Good afternoon, and welcome to Medical Education Grand Rounds. Thank you all for coming. There will be people who straggle into the room, I'm sure, over the course of the next 5 or 10 minutes, but that's fine. We just wanted to get started to give the speakers enough time to speak and to give the audience enough time to ask questions. So I have the great pleasure of introducing the two speakers today. They don't really need introductions because we all sort of know who they are, and so my job is very easy. But I do want to say a couple of things. So both Dr. David Thomas and Dr. Reena Karani will be presenting what they presented for their thesis defense when they went to Chicago to capstone their Master's in Health Professions Education. I was privileged to join them on that sweltering hot Chicago day. And they did an absolutely fantastic job, I can say, as a first-hand participant. And then, of course, Reena dragged us to this greasy hot dog joint that was the hot dog joint in all of Chicago. But it was a very special day and a special occasion. And I think as a Department of Medical Education, we try to do many things well, and then all of the things that we try to do well, we try to make sure that we disseminate. And the key to dissemination is publishing and presenting around the country, sometimes around the world. And they really have, I think, of all of us, have taken the lead in that. They've done it for years and years and have been out there and have built an incredible network of colleagues for themselves that they then graciously extend to the rest of us. And I think that with this new credential, this new master's that they each have, I hope that they continue to build that as a resource for all of the rest of us as we strive to disseminate. So the first presentation is from Dr. David C. Thomas, MD, MHPE, Master's in Health and Professions. Anyway, the title is Residents' Perspectives on Rewards and Challenges of Caring for Ambulatory Patients with Chronic Illness. David Thomas is Professor of Medicine, Medical Education, and Rehabilitation Medicine. He is Vice Chair of Education for the Samuel Bronfman Department of Medicine and Associate Dean for CME. And immediately following David's presentation, Reena will present her thesis defense, which is entitled Medical Students Learning from Residents in the Workplace. Dr. Karani is Associate Dean for Undergraduate Medical Education and Curricular Affairs, Director of the IME, and Associate Professor in the Departments of Medical Education, Geriatrics, and Medicine. I think it's your guys' preference whether you want to pause and answer questions in between or after? At the end. Okay. Welcome, Dr. Thomas.
Thank you, Dr. Moore. So thank you very much for having us here. And when we were first thinking about this, the idea of presenting today without having Reena at my side was unacceptable because we had gone through so long in this program together. And, at UIC, Mount Sinai is a very well-known presence at Mount Sinai, I will tell you for sure. And then having David at our defense really added to the highlight of completing, all these years and many early mornings of work. So I'd like to take you through and let you see what I did. I focused on the graduate medical education level stuff. I have no disclosures. And at the end, I hope that you will be able to think about the rewards and challenges that internal medicine residents perceive in caring for patients in this setting. And I think you'll see that this is a very topical area for us. And then to think about the chronic care model, which I use as my conceptual framework, and then to incorporate residents' perspectives into design of practice and curriculum redesign, which is really what comes out of this. I've been thinking a little bit about, everyone in here is aware of the changing demographics of the U.S. and where we're going, and chronic disease and illness is becoming where we are seeing patients, and especially in the ambulatory care setting. At this time, when I started, I was the medical director for the AmCare for the department, and so really thinking about AmCare issues. Internal medicines are not trained in this way. There is an acute episodic model, as those of us who went through the training know. But there are thinking of how we can develop new models to improve quality of care. One of these models is the chronic care model, which has received a lot of attention and leads its way into sort of patient-centered medical home from its pediatric component. And these are the components it has 6 components that Wagner described. And I'll show you how they break out in a little bit more detail. And these are the descriptions. So if you're not sure about it, so self-management support sort of looks at educating and empowering and preparing the patients. Delivery system design thinks about assuring effective and efficient clinical care and self-management. Decision support really looks at the evidence-based perspective of how people are approaching their patient care. Clinical information systems looks at patient and population data in organizing and facilitating effective care. Community resources, and how do we mobilize our community partners to help care for our patients? And then healthcare organizations, which is interesting to think about. What is the culture of the organization as it affects the interaction of the patient in their care setting? So there is some background to this, but not much. It's very little literature on this with terms of resonance. And there was a qualitative study that looked at the challenges in providing chronic illness care that was done in specifically a resident clinic that had directors of grant-funded residency-based programs. So it was a fairly small number of people. And in this, the themes that came out for them were that of engaging faculty and residents to spend limited time in the clinical practice, which we all know exists in the clinical training centers. And then there were institutional barriers that came out as a theme, and they were the authority, who had the authority, the competing priorities, and limited resources. I think something that everyone in here can relate to. In another project around this, where people implemented the chronic care model on asthma-related ED visits and the residents' use of the chronic care model. So they implemented the chronic care model, and they looked at these outcomes and using a pre-post survey design. And the outcomes that they saw, there was an increased knowledge of asthma guidelines, which was nice. A larger proportion of patients received those guidelines, and access to information about the community increased. And they did see asthma-related ED visits dropped, although it was not statistically significant at the time, but they saw it trending downward. So we see evidence that implementing the chronic care model in the outpatient setting works. But the aims of my study was to go a little bit further and to look at what the residents perceived. I really feel strongly about the residents' interaction. They're the ones who are in there. They're a very large percentage of who's in that practice around the country. So what do they perceive as the rewards? Okay, this is very hard to do, take care of chronic patients in the outpatient setting in the current episodic model. But also, and to understand their challenges too. So what is it that they're living within that may be different from what an attending is living in? And then how best can we enhance that? The ultimate aim was how can we enhance their education to improve the patient outcome? The conceptual framework that I used was the chronic care model, and this is what I used to develop my focus group questions, which I'll show you shortly. So the methods, and the study design, it was a qualitative study design. It was multi-institutional at 3 institutions. It was here at Mount Sinai, where I was the lead investigator. At the University of Illinois, Chicago, where there's a lead investigator, as well at the University of Michigan Hospital and Health Systems. All the residents were PGY 2s or 3s, and they were all recruited during their ambulatory care rotation. Residents were invited to participate by email, and they were able to opt out if they did not feel comfortable. And the focus groups were conducted during the ambulatory care morning report at all 3 institutions, with 8 to 12 residents recruited per site in order to get enough residents total for the whole investigation. It was led by different site investigators, but we tried to standardize the focus group interviews by faculty development, conference calls, emails, and the development of a faculty guide in order to limit the variation between sites. PGY year, gender, fellowship, and career plans were elicited and de-identified during the process, and open-ended questions were used to explore the aims of the study, which were all developed out of the chronic care model as the conceptual framework. These are the questions. It really revolves around asking specifically around the rewards and the challenges. Diabetes was used as the anchor so that they could really put their mind onto what was going on. What were the strengths of the residency program? What did they identify at the moment? What they could do better. These are really smart people, and it's obvious you'll see from the themes that come out of this. And then what else can you add about taking care of patients with chronic disease? So our data analysis. The data was analyzed by 2 authors, coded independently. The transcripts were reviewed for themes. The content units were words and phrases. Intercoder agreement went from 75% to 100% after discussion between the 2 coders. And then the data was evaluated for trustworthiness via member check and triangulation with the published literature on chronic care model. So what were the results? These were our demographics. About half were male and female, about the same for PGY 2s and 3s. That PGY 4 is a med-peds resident. The career plans, majority were ambulatory care, but a good proportion were hospice, and the other were various other things like administrative type positions. And then the majority were planning on a fellowship. So the domains. So these were the domains that I looked at for the themes, and they were the challenges and rewards, the strategies to improve the patient experience, the strengths of the residency program, and then ways you could improve your training. So what we're going to do now is look at each domain according to what had the most themes associated with it. So the challenges in providing care had 32% of the comments and developed 12 themes totally. The number in parentheses after the themes represents the number of comments for that theme. So competing responsibilities and time limitations were obviously a strong part in the challenges for the patient, for the residents providing care. The patient's lack of resources was a big challenge for the residents. The feelings of failure by a provider was an interesting theme that came up from the resident's perspective. The provider frustration with patient non-adherence, the lack of continuity between patient and provider, and the patient cultural issues. These still developed. There was still some more themes with patients don't feel symptoms of underlying disease, if the residents recognize this, getting buy-in from patients to do the recommended treatment, the difficulty for patients to make needed follow-up visits and frequent visits, comorbidities in the patients, provider frustration with staff in clinic, getting to the team, and medication misconceptions came up. Now remember, this is across 3 institutions that all coming up with the same stuff. So the rewards in providing care represented a quarter of the comments and had 3 big themes, and I thought this was very nice to see. So a large majority of the residents saw seeing patients empowered, educated, and succeeding in partnership as being very exciting. The long-term relationships they valued in this context, and then working in teams came up as a theme within the rewards that they saw. So the residents definitely found rewards in caring for their patients. Strategies to improve the patient experience had 16% of comments and had 8 themes in total. So strategies that they improved was educating their patients about their care. They were finding more time in ambulatory settings to improve resident education, so that they thought was a strategy that they would use. The time management by provider came up in pretty interesting detail. Managing your own appointment calendar as really a way of getting around some of the systems barriers. Improving the clinic scheduling process. The review of labs and writing to-dos prior to a visit. Simplifying IT systems. In some of these places, there was multiple systems that were required to be used, and then the use of questioning helped improve the patient experience. And how about what did they see as the strengths of their residency program in educating how to provide care? 14% of the comments were on here, and there were 7 themes. So the strengths were seen as all the patients with chronic disease were definitely seen as a strength for the residents. The volume of patients was both a pro and a con in many instances, but here they saw it as a strength. Their specialty clinic rotations and where they rotated and all the different specialties. The urban setting was seen for these places. The time in ambulatory care visits, the ownership of the patient, they saw as a strength, and then the consistency of ambulatory care preceptors. And what ways did they see that their residency could improve on how to provide care? Had 13% of the themes, percent of the comments, and 6 themes. Use of more team members in the clinical setting. Improving continuity scheduling and with the provider and the patient, they recognized. Education about community resources was seen as a way. Orientation of staff and team members, facilitation of chronic disease measurements in clinic, like hemoglobin A1Cs, for instance, or incentive spirometers done by the team members, and then education on how to counsel patients. So the discussion, so that was the theme. So let's think a little bit about what this means for us. So the internal medicine residents, I think, is very interesting. They're definitely able to identify the challenges, but that's usually where the discussion ends. And the discussion usually ends on the challenges that are taking care of patients. But they're definitely able to identify the rewards in caring for the patients in the ambulatory care setting. Simultaneously, they develop their own strategies to improve patient care, the patient experience. They did see strengths in their residency program and how they're educated about this. Some of those were both strengths and ways that they thought were challenging, for instance, the large volume of patients. And they identified concrete approaches for how the residency can improve their learning of how they can care for these patients. So let's think a little bit now about how this relates to the chronic care model and the themes that developed out of this. And what we were able to do is map the themes to the chronic care model as a conceptual framework and see how that can help facilitate us at the other end. So for instance, in self-management, so essentially here, the top bullet is what the chronic care model is, and these are themes that map to them. So the self-management support, so seeing patients empowered, educated, and succeeding, okay, in partnership with physicians, was a theme that linked to the chronic care model, as was education of patients and use of questioning. Delivery system design, they saw ways to better enhance the specific process of how the clinic runs. So they identified these and gave specific examples of ways that they thought we can improve, and also ways that residents can work within the teams better. So they were able to participate in the dialogue of what's going on in the healthcare environment at the moment. These are some examples of some more concrete. The delivery system design very interesting because it got very, very concrete. So they saw as long-term relationships, working in teams, the scheduling process, or systems-based stuff they saw as very critical to improving the delivery system design. Decision support, so what is the evidence? How does the evidence interact with the caring for the patient? So the specialty clinic rotations where they could develop that knowledge that they needed to care for patients, and then more time in the ambulatory care setting. They thought would be critical in order to improve this. And then clinical information systems, they were looking to simplify the systems. How do we get around all the barriers of multiple systems, the many patients with chronic diseases, and simultaneously the volume of patients that came in. And community resources, education about the community and urban setting. They recognize, their themes came out recognizing that what is important in the chronic care model. And then healthcare organization, they saw that the culture of the clinic mattered to how they cared for their patients. So in summary, the chronic care model and the themes, some of the themes directly map. They identically map to the chronic care model if you look at all the description of it in detail. But most of the themes generally fit into this, into the chronic care model. And many of these themes end up being building blocks for the chronic care model too. What is ultimately the idea behind this is to support the development of curriculum around the care of patients with chronic disease in ambulatory care setting. And also residents are able to tell us how we can redesign the practices that they work in. And having the stakeholders involved like that, I think, would be a critical component. There are limitations and some directions that we hope to go forward with. These were conducted at 3 very large academic medical centers. It was only internal medicine residents. All 3 of these were internal medicine residents with 1 med-peds resident in there. It was a convenience sample of residents on their ambulatory care rotation, and that's how we had to design it to get who we needed. And then the focus groups were conducted by different facilitators, but like I said, we did faculty development and conference calls in order to try and limit that variability. Hopefully, going forward, this can be extended. Like I said, there's little in the literature about this. To use a wider sample of more diverse internal medicine residencies, so rural settings, things like that. Other specialties, I think, would add a lot of dynamic influences to this. A survey would enable a much larger sample, of course, but in terms of sort of generating the theory that was needed at this point and the questions, that's what the focus group and qualitative approach was. Expand to medical students and attending faculty and sort of get the whole continuum of care. And then to ultimately develop curriculum across the continuum of the healthcare professions, and then to evaluate what these long-term outcomes could be going forward. So in conclusion, internal medicine residents can identify both challenges and rewards in caring for patients with chronic illness in the ambulatory care setting, without a doubt. They provide specific comments which can be used to support the development of curriculum across in ambulatory care with using the chronic care model, and internal medicine residents practice redesign. So we can redesign the practice using the input from not only the residents but the chronic care model, and we see that the residents are already able to dialogue in that. So that is the end of my presentation, and we're going to move on to Reena's, and then we'll come back for questions afterwards. Dr. Karani.
So the topic of my talk is entitled Medical Student Learning from Residents in the Workplace, and I too have no conflicts to disclose. So in terms of conceptual framework for this study, what we're looking at is situated learning theory, and that suggests that learning is inextricably tied to the context in which we are learning. So that being socialized into a community of practice is really influences how we learn and what we learn. And when you think of education in the professions, things like medicine and law, that learning in the practice setting is really the signature pedagogy. So that distinguishes the learning we do in sort of professional learning from learning in other fields. And for medical students, if you apply that theory, then clerkships are really the entry point into the professional community of medicine. So what happens during clerkship? So one is students gain the knowledge and skills required for practice. They develop an appreciation for the patient experience. They integrate into the healthcare team. And they also experience professional socialization. But for learning to happen in this community of practice for medical students, you require teachers who supervise the development of both technical skills and applied knowledge, but also who serve as role models for the attributes of the profession itself. Now, residents, let's think about them in terms of the context of teaching and medical students. So residents are really most directly involved in caring for patients here at academic medical centers, and they spend the most time in direct contact with students. In fact, the literature shows us that up to a third of medical student education is provided by residents, and students say that residents are their most important teachers. Residents at the same time value that role in teaching, and they want training to be effective educators. As a result, we have resident as teacher curricula that have developed, henceforth known as RAT programs, and they have been recommended by the accreditors at the undergraduate and graduate medical level. A study in 2001 looked at US programs and found that over 55% of them offered such programs, but there's tremendous variation in terms of the content, the length, the methods, and the format of these programs. When you look at the most prevalent models of RAT programs, the Minute Preceptor, the Stanford Faculty Development Program, and David Irby's Domains of Clinical Teaching are by far and away the most common methods used in RAT programs around the country. But what's really interesting is that the teaching strategies and the content emphasized in those models were really derived from the behavior of clinical faculty. And the literature on what students actually learn from residents and how residents teach students is really lacking. In fact, this critical gap area really creates an opportunity for us to learn more because those resident as teacher curricula could then be tailored to the teaching roles that residents actually play and really focus on the actual learning needs of students, the stakeholders. So the aims of our study were to determine these two areas that I'm going to talk about today. There were a couple more aims that I'm not going to present here. But first is, what do third-year medical students learn from residents in the clinical workplace? And which teaching strategies are used by residents in their interactions with students? And the aim for focusing on these two important questions was really to help us then think about how to focus the content and teaching strategy of resident as teacher programs going forward. So our methods was a multi-institutional study at Johns Hopkins, Sinai, and the University of Chicago. It was a qualitative study of third-year medical students who were midway through their third year. And we asked that they had completed their surgical rotations and either their medicine or pediatrics rotations in an effort to provide students who had completed the majority of their largest rotations, as well as the most dissimilar in terms of culture and tasks, procedural and non-procedural. So students were invited by email to participate, and at each site we had 2 sets of focus groups. There were 6 to 12 students per site, and just like in David's study, we had site investigators at each of the places. And we obtained gender, age, career plans if they knew them in a de-identified manner, and then used open-ended questions to allow for their exploration of ideas. The focus group questions that we used, and I'll talk about today, are the following. Describe the types of things you have learned from your residents during the clerkships. What do you view as the most important things you learned from your residents this year? and describe the qualities and skills that make a great resident teacher for medical students in the clinical workplace environment. So two authors coded the data independently. We reviewed the transcripts for themes, and the contents, of course, were the phrases and words. Our intercoder reliability was 88%, and for conferencing was 100%. And we too used member checking, where in this case, students would review the transcripts for accuracy, as well as the themes that were derived for effectiveness in capturing their perspectives. And then we also triangulated our data with published literature on clinical teaching and resident teacher programs. So let's look at the results. We had about an even split between males and females. The mean age was over 26, and about half had an idea about what they wanted to go into as a career choice. I'm going to divide the results up by looking at the two areas. One is the teaching methods used by residents, and then the knowledge and skills that students actually learn from their residents. So let's look at this. So in terms of teaching methods, we categorized 228 comments into 20 themes that were then organized into these 7 domains, and they're listed from the top of the slide to the bottom in order of density. So role modeling by far and away was the most common method of teaching by residents, and here it was defined as setting an example through behaviors and actions. And the themes under that were setting the example, admitting limitations, applying knowledge to clinical care, and advocating for patients. The second most common method of teaching was by focusing on teaching, meaning by being deliberate about and demonstrating a commitment to and interest in teaching, which represented in comments that focused on residents finding teachable moments, taking actual time to teach a student, and then showing an active interest in teaching itself. The third theme in terms of method was creating a safe learning environment that is actively facilitating an atmosphere that is non-threatening, open, and conducive to learning. And here residents offered students opportunities for safe practice. They established rapport with students. They offered reassurance, created a sense of team for the student, were open to questions, and occasionally used humor. The other way that residents taught is by providing experiential learning opportunities. That is, offering opportunities for meaningful and active participation and supervised practice. So here they offered students the opportunity to take ownership of patients and involve the student in the team. The other way of teaching was by giving direct feedback, meaning providing specific positive and constructive feedback to the student. Setting expectations was another lower density teaching method used by residents, and that was setting clear expectations for student performance and explaining the student role explicitly. Residents also stimulated student learning by doing two things. They challenged students to learn and directed students to the seminal literature of an area. So we'll reflect on these when I look at the conclusions from this study, but let's move on to actually what did students learn from residents. We know how they were teaching students, but what did they learn? So here we categorized 197 comments into 33 themes that were then organized into these 9 domains. And once again, the domains are listed in order of density from top to bottom. In terms of patient care, by far and away, that was the most common knowledge and skill area that students learned from residents. They learned how to link previous knowledge to actual clinical care now that they were in the clinical environment. Clinical reasoning was an important theme they learned, as well as how to manage patients, how to do physical exam skills, how to prioritize among different patient care tasks, what were the actual logistics of doing procedures related to picking up equipment and being prepared at the bedside, history-taking skills, and some reassurance and empathy toward patients. The next domain was communication, where they learned not just how to communicate with a patient, but from the resident, they learned how to interact with all the different people on the team and around them on the clinical environment. They learned how to present cases in different types of rounds, how to call for consults, how to write patient notes, and how to give effective sign-out. Navigating the system are the logistics and hierarchy and division of labor that happen in this very complex clinical environment. Students learned how to get things done on the floor. How does the system work in the hospital? What's the hierarchy? And who do I go to for things? They also learned an important thing that we often don't talk about, but the idea of adaptability. And that is, how do these residents function in terms of their balance between work and life? How do they respond to stress? How do they respond to criticism and feedback? How do they think on their feet? And how do they develop and modify their routine to be nimble? So that was an interesting area that emerged from the student data. They also learned how to function as a student and resident. That is, what are the roles and expectations of me as a student? How do I function as a resident? What do I see my resident actually doing? And how do I make that transition from the preclinical environment into the clinical workplace? They learned lifelong learning skills, how to be more self-directed about your learning, what's the technology that you can use at the point of care to actually facilitate patient care, and how to read the seminal literature. There were a few low-density comments in the terms of what not to do, what are things that you should just not do, and what to do, like what are some of the things you might just want to do on the floor. And a low-density area was career and professional development. A few students commented about getting some career development advice from residents and learning more about the culture of different fields from residents. But by far and away, the least coded comments from students related to medical content, and we'll talk about how interesting that is in a few seconds. So let's look and reflect upon these results. Let's look first back at teaching methods. And now let's go back to those three most common models used in resident as teacher programs. The first is the 1-minute preceptor, and this was designed actually for use by faculty preceptors for residents in ambulatory practices. And it includes behaviors for us as faculty member to understand residents' decision making. And it includes 5 micro skills. How do you encourage the learner to make a commitment? Ask the learner for evidence to support that commitment. Provide general information to the resident. Offer feedback, and correct errors through constructive feedback. So those are the 5 micro skills in the 1-minute preceptor model. So if you look at our themes in terms of the 7 domains that we found about teaching methods used by our residents, the one that does map directly to this model is feedback. What about the second most common model? That's the David Irby model of clinical teaching excellence. And this includes the domains of knowledge that were utilized by distinguished general internal medicine faculty during teaching rounds. That's how these themes were derived. And they had 6 domains. The faculty member had to have a clinical knowledge of medicine, patients in the context of practice, educational knowledge of the learners themselves, some general principles of teaching, and case-based teaching scripts. And that's what distinguished these very, very senior faculty members as excellent educators from other faculty members. So when you look at our themes of teaching methods, there are certainly some themes that fit this model in terms of the general principles of teaching. And those are things like showing interest in teaching if the resident takes time to teach, the resident gives feedback, and establishes rapport with the students. But there are many themes that really actually don't fit the Irby model because they pertain much more to the longitudinal workplace-based experiences that students have with residents. Things like offering opportunities for safe practice and ownership of patients, providing experiential learning opportunities to students, and involving students in the team. What about the SFDP program? So this was based on education and psychological theories of learning and observation of clinical teaching. And what the SFDP program did is then develop a clinical teaching instrument that has been widely validated and widely used. And the instrument has 7 domains: the learning climate, how you control the learning session, how you as a teacher facilitate a communication of goals, how we promote understanding and retention, evaluation, feedback, and self-directed learning. And those are the domains in the validated SFDP scale. So many themes that we found fit under the broad SFDP domains, but most of our themes actually do not match the validated SFDP clinical teaching instrument. So here's an example. So in the domain of promoting understanding and retention, which the SFDP program describes as using teaching methods to promote understanding and retention, their clinical teaching valid instrument has these 3 statements: presented well-organized material, explained relationships in the material, and used the blackboard or other visual aids. So if we think of themes in our study that don't directly fit but could fall under this general category, things like providing experiential learning opportunities and giving students ownership of patients could certainly help facilitate understanding and retention among our learners. The domain of control of session, the description is that the teacher uses approaches to focus and pace a teaching interaction. And the validated tool has these three statements. The teacher calls attention to time, avoids digressions, and discouraged external interruptions. And so if we think about what might fit into this domain for us, we have things like finding teachable moments. But as you can see, none of our themes directly fit the actual validated instrument statements. So what does all this mean? Interestingly, for us, role modeling was the most frequently classified method of teaching used by residents. And this is not emphasized in any of the RAT programs. In fact, for us, we identified several strategies that are very specific to workplace-based learning, involving students in the team, offering them opportunities for safe practice, and giving them experiential learning opportunities. And these really, our take-home point on this is that these require focused emphasis in new RAT programs. What about the knowledge and skills learned from residents, and how does this fit with our paradigms that we are using currently? So for us, the major themes were patient management, communication, navigating the system, and an ability to adapt and adjust is what they learned from residents. But none of those themes fit well in the current RAT models. The 1-minute preceptor asks learners to commit to and defend a diagnosis or plan. Irby's model emphasizes a knowledge of medicine and patients as the key domains. And the Stanford Faculty Development Program fits much more for formal clinical content presentations that you might deliver as an instructor. So where do our findings really fit? And I think our findings fit much better in research that has been related to students' perceptions of their transition to clerkship years. And this literature is an emerging literature. O'Brien found that the most prevalent struggles among students who were transitioning from the preclinical to the clinical years were the logistics of the clinical environment, how to manage patients and their problems, how to communicate appropriate information, how to contribute to patient care in different settings, and finally, the roles and responsibilities. And you can see as I read these that these vibe much more with the themes that we identified in our study. So in summary, in terms of knowledge and skills, the most frequently coded areas of learning relate actually to the context of the clinical workplace environment and the social relations and practices that happen in there. And these really require focus emphasis as we redesign RAT programs. And I'm going back to this idea of medical content. We often put a lot of emphasis on thinking that students are learning a ton of medical content from residents, and our data suggest otherwise. In fact, it's perhaps that students learn a lot more content-related information from attending faculty and from their clerkship didactics, where they're really focused on content as opposed to these areas of working and relating in the clinical workplace. So this study too has limitations. As David mentioned, we had differences in facilitation and questioning style, although there was a lot of faculty development and the questions were standardized across all focus group sites. We had students who completed clerkships in surgery and either medicine and pediatrics, which might limit the generalizability of these findings to other fields. And we did not include residents in this study, which gives us a wonderful opportunity for future directions. So two things are happening. One is that we are looking at the data now to see if there were differences in any of these areas related to students who had done either surgery and medicine or surgery and pediatrics, to actually look at the by clerkship differences and see if students learn different things from residents in different fields. We're also going to study the resident perspectives on teaching medical students themselves to see if that triangulates with what students think they're learning and they feel the way residents are teaching them. It leads to an idea of doing an observational study of resident teaching behaviors in the clinical workplace environment, of course. The development and evaluation of RAT programs has been an area of great interest following this study in terms of actually redesigning and developing a model of resident as teacher programs. And finally, the idea of development and validation of a resident teaching instrument, just like the SFDP program, but developing one of those based on the themes of our study so that you could actually give feedback to residents as they're teaching students in the clinical workplace. So in conclusion, what we found is that strategies specific to workplace-based learning should be incorporated into RAT programs. That is, offering opportunities for safe practice and ownership of patients, providing students with experiential learning opportunities, and actively how to involve students in the team. And we have to think about how to actively prepare residents for role modeling. And Cruz and Schoen have shown that there are actual ways for us to acknowledge and teach role modeling. That is, first, to be aware of the importance of role modeling as a teaching strategy, making the implicit explicit whenever possible, articulating what you're modeling as you do something with the patient, and then taking a moment to articulate what you're doing, and then having an opportunity for the learner to have facilitated reflection on the behaviors and attributes that you are demonstrating. So I think that that's a key component for us to think about when we look at these data and realize that role modeling is indeed one of the most common ways that residents are teaching students. And finally, the students learn different things from residents than they do from other members of the healthcare team. Surprise. They learn patient management, communication, how to navigate the clinical system, how to adapt to this environment, and their roles and responsibilities. So I'm going to end there, and we're happy to take questions from you about either of our projects.